Mr Mills.
My lady. Professors, can we next look at the issue of training? Is there specific training for healthcare professionals working in long COVID services?
There's been education packages written for primary care from the Royal College of General Practitioners. Most of us, as I was explaining, sort of started off from the respiratory, the lung side, because of the follow-on from hospital admissions. So at the moment, there's no formal training. You know, if you're going to medical school through to junior doctors, you won't do a section in post-viral syndromes or long COVID, and we're not, and particularly if the long COVID clinics are reducing, actually you're going to have even less people with the expertise in long COVID to actually help support that training.
As well as that, do we also see a variation in the type of clinicians delivering these services?
Yes, there's a huge variety, from people like myself as a lung physician to people from infectious diseases where they have looked after people with post-viral syndromes before, to general practitioners that specialise in fatigue. There are some services where there aren't any physicians involved, so that multidisciplinary team is really just the allied healthcare professionals and the nurses without the medical support.
So if we take these points together, different training potentially and different clinicians, is this a recipe for variations in approach?
There will be variations in approach. I think I would be less concerned about the background of the person delivering a service, as long as they have got the skill set to be able to deliver the service. And I think going forward, we definitely need to think about that more carefully and plan for that.
At paragraph 35 of your report, you describe that there was initial consternation on the part of clinicians that in October 2020, as we've discussed, long COVID clinics were set up, but not rehabilitation services. Can you help us with the reasons for that consternation?
Yeah, so if you're, there is value from meeting a healthcare professional, hearing about what your symptoms might mean, validating those symptoms, having an empathetic response. We've seen in the qualitative evidence that that's very important. But ultimately, people want something that's going to help them. And those non-pharmacological strategies, including rehabilitation, are really important. So as somebody leading a service, if you didn't feel that you had the interventions to then support after your assessment, you definitely felt that that was going to be suboptimal.
And we'll come on later to think about some of the rehabilitation services that we have. Before I move on, can I ask you this finally about referrals? At paragraph 37 of your report, you record that at the time of writing, following approximately 125,000 referrals, 113,000 patients have been assessed by a specialist long COVID service. To what extent are the two of you encouraged by these figures?
So I'm encouraged that people have been seen and there are long COVID clinics, but if we think, and I'm certainly not going to infer that all 2 million people that are living with long COVID need to see a long COVID specialist, but I would have thought that the 100,000 that have is leaving a big gap of people that are experiencing very difficult symptoms that are impacting on every facet of their life and not getting the support that they need.
Professor Breitling, do you tend to agree?
I think it's a good start.
It's an encouraging start. And if we had confidence that the clinical service was now beginning to expand and accelerate, then I'd be very pleased with those figures. What you've already heard from Rachel is a number of the services are already under threat. There's likely to be a shrinking of the clinical service next year. The services are not the same across the 4 nations from the get-go and are very different now. And this has enormous impact then on training, as you've alluded to, and also research, which needs to be integrated into clinical care. So the clinics have to be the foundation of then actually being able to find solutions for people with long COVID.
Can we move to Wales? Is it right, by way of summary, that the Welsh approach has not been to establish specialised long COVID clinics, but instead to deliver long COVID services through primary care? That's
correct. So in the summer of 21, the plan was to fund a primary care network at the cost then funding of £5 million. And that then included therapists and primary care physicians. But if you needed to then refer on, you were referring on to a whole variety of different organ specialties. That funding was then renewed for a further year, and then the funding has been continued, but the funding has now been taken into support for long-term conditions in general. So there isn't a specific pot nor the service exclusively for long COVID.
In your view, are there any advantages to the Welsh approach?
So it's clearly correct to be able to offer help and support within the community. But by having the support exclusively in the community and then to have this very disconnected secondary care support has a number of disadvantages. It has a disadvantage to the patient in terms of being able to have a one-stop clinic and being able to get the best service as quickly as possible. It then has implications for training, because there then isn't a group of specialists that are then actually evolving the subject area. And it also then becomes a barrier for research and taking things forward, because you then don't have a base in which to then be able to look for new diagnostics, new disease understanding and new therapies.
If we have in our minds perhaps the gold standard, do we need both specialised long COVID clinics and the appropriate training within primary care to make sure people are referred to them?
The simple answer is yes. But I would suggest that we can compare this with some of the other disease areas. You asked us very early on to think about the relative prevalence of long COVID compared to other chronic conditions. And Rachel referred to chronic obstructive pulmonary disease and heart failure, which are very common respiratory and cardiac diseases with a very similar prevalence of 1 to 2 million. If we think of heart failure as an example, the British College of the British Cardiology Society and the British Heart Foundation did a recent survey. So there's around about 1,700 consultant cardiologists in the country. And of those, about 1 in 8 consider themselves primarily as heart failure specialists. So that's over 200 heart failure specialists. If you think of full-time equivalents of doctors that would then say our primary role is actually being a long COVID specialist, then that really is down to single figures or even only 10 or so. So the contrast is if you were going to put people onto a double-decker bus in central London, you'd need probably 3 double-decker buses for the heart failure specialists, whereas if you had a people carrier or a small minibus, you'd probably have room to spare if you were to then fill them with people with long COVID specialists. So there's an enormous contrast between the two.
At your paragraph 77, you observe that services differ between the 7 health boards in Wales in terms of staff composition, durations and types of intervention. I wonder, what are your views on that level of variation?
I think that's actually probably also an understatement. As I've said, that now the care has moved away from those long COVID services into long-term disease clinics. So it's likely that there's probably even more variation in terms of the type of care. And I think this is a disservice to the patients, because clearly you want that, as you described earlier, that multidisciplinary team approach with that one-stop clinic where patients are then able to get an early diagnosis and then bespoke treatment for their own problems.
Scotland, please. How were long COVID services initially provided in Scotland?
So in Scotland, again, there was a delay in setting up services. So this was really into the last third of 2021. There was £10 million of funding to set up those clinics. The clinics really were quite challenging because the services simply couldn't cope with the number of referrals, and the clinics have then been disbanded as long COVID clinics, and then the activity is then, and the referrals have then been taken up in a variety of long-term condition clinics across the different parts of Scotland.
Yes, at your paragraph 29, you explained that one of the long COVID services in Scotland was unable to meet demand and closed after 18 months due to a lack of funding. Do you know whether any reason was given for the lack of funding in circumstances when demand was clearly high?
No, we don't.
Northern Ireland, is it right that until November 2021, there was no central funding for long COVID services in Northern Ireland?
So we're aware that the Northern Ireland model, again, similar to Scotland, came later in terms of then setting up multidisciplinary teams. How that model was funded is something that is unclear to us and is not in the public domain.
Are you able to help us with the position before the funding was applied in November 21? How, if at all, were long COVID services developing in Northern Ireland before then?
So obviously neither of us have any direct workings in Northern Ireland, but anecdotally from colleagues, it definitely appeared that the structures were not well formed, and that it was not until those multidisciplinary teams were then created where there was actually some form of long COVID service. But like all of the countries I've described, really the services have not been exclusively for long COVID in a long-term nature with long-term funding.
Can I take all that we have discussed about long COVID healthcare in adults together? The long COVID core participant group describes the provision of long COVID services across the UK as a postcode lottery. Do you agree?
So I think they have a very valid point in that we recognise what is the right kind of care model, and how that's been delivered from the get-go has been different across the four nations. And with the clinical services even in England, which was better funded, the types of services, as Rachel's described, is different between different centres.
And are you able to help the inquiry understand the consequences of that disparity for patients?
So I think what's worrying is not just that the consequences of the disparity now, but the likely consequences of that ever-increasing disparity as we then go into next year. So at the moment, then there's differences in terms of the training and confidence in primary care, the referrals. There's then differences then in terms of the level of care that's then done in secondary care, who's delivering that, and differences across the four nations, with funding, as you can hear, then decreasing. The long COVID clinics and the services are largely driven by people who still have other specialist roles, whether that be in respiratory, cardiology, infectious diseases, and others. And the pull has been very much to pull many of those people back to their original areas of specialty. So there's a real risk if you start to undermine the clinics, that then the whole discipline of being able to look after people with long COVID starts to become undermined. And then that then clearly has consequences in terms of training and future research. So the very strongly held view is from us is that the clinics are really the foundation to which all the other elements are also necessary, but then can then feed into those clinics, and the clinics can then be the axis as well for delivering research and training. So providing those clinical services is absolutely paramount.
Long COVID SOS has described the benchmark that long COVID care should meet in the following way: a one-stop shop with a mix of specialities, professionals allied to healthcare, and, importantly, a point of contact for the patient. Can I ask whether you agree with this as a description, and whether so far, in your view, this benchmark has been met?
So I agree, and in some cases, yes, but in many, it's fallen short.
Can I just ask, I understand exactly what you're saying, and supposing I were to accept your opinion and make a finding and or a recommendation, for those who are of the mistaken view that COVID is over and therefore we just need to get on and get people back to their original specialisms, as you were saying, Professor, could the clinics, if they were funded, these one-stop shops, could they be used for other conditions? In other words, could you persuade the money people to spend the money, because it's not just going to be dedicated to COVID, that they, as I say, mistakenly believe is over?
The simple answer is yes. I'd love to be of the view that long COVID can end up being been and gone COVID, where it no longer is a concern in the years to come. I think until we have new effective therapies, that will be some time yet.
I understand that.
But I completely agree with the point that you've made, is that there are other conditions, other post-viral syndromes, so ME/CFS is an example, where you could then have services expanded in those areas, and then also to include services for long COVID and possibly other conditions. So overall, these conditions are not going to go away in their totality. Rachel, I don't know if you want to add.
Yeah, so absolutely agree. And unfortunately, I think there is this belief that long COVID somewhere along the line is going to disappear. And we've seen from ONS that's not the case. You asked me earlier about post-viral syndromes. This could be the proper legacy to get this right for next time. If you've got these experts, you've got these expert clinics, then for the next viral pandemic, you may need to bring in other specialists. It may look different, but at least you've not lost that core knowledge from this, and that's really vital.
And on that core knowledge, do we now have evidence that long COVID clinics are both clinically and cost effective?
Yeah, absolutely. I just want to put one further caveat to the one-stop shop, because I think long COVID SOS, and certainly my interpretation, is meaning for that assessment that we're not spreading specialists. But definitely there needs ongoing support and ongoing care, just like for any other long-term condition. Those clinics, if they have complex diagnostics, complex assessment, complex interventions that are personalised, we've shown data that shows that they are clinically effective and cost effective. And as Chris has highlighted, there's a whole other reason for needing those clinics for research, training, and for future pandemics.
New topic, please. Access to healthcare and treatment for children with long COVID. Can long COVID present differently in children and young people compared to adults?
So first of all, neither of us are paediatricians, so we've been very fortunate to be able to work closely with paediatricians, and some of the text within our report is then from discussions with paediatricians. So the main symptom clusters are very similar. There are some additional syndromes that can occur in children, but many of the things that you are concerned about in adults are also relevant to children and young people.
As far as you are aware, are there any dedicated services for children and young people with long COVID in Wales, Scotland or Northern Ireland?
Not as far as we're aware.
Again, as far as you are aware, have attempts been made in these countries to introduce such services?
They may have been, but not as far as we're aware.
No, I think I think there was concern around the lack of volume of patients to require dedicated clinics. I'm not saying this is my belief, I'm just saying that's what was postulated, and therefore it was felt that the people, children and young people with long COVID could be dealt with paediatric services in specialist care.
If we consider the position in England, then, can you help us? How have long COVID services for children and young people developed?
So it was slower than for adults. So just like we were hearing, there were delays in understanding and delivering healthcare for adults with long COVID. There was even more delay for children and young people. Eventually, there were 15 clinics set up. I think this was largely due to the enthusiasm for one site at London that really did lead this, and then NHS England supported delivering 15 clinics. I think that's the maximum clinics that we've ever had, and I think there are, again, at least some of those that have since closed.
You describe in your report that those clinics utilised a hub and spoke model. Can you help us with how that model operates and what the advantages are of it?
Yeah, so I think similar to the concerns from the other nations about the volume and the number of clinics needed, it was felt to have these specialist clinics where you can really get the specialist knowledge, the specialist teams, and then they would actually then be a sort of port of call for other paediatric services to get advice. And certainly the virtual MDTs, again, were open to other clinics, is my understanding of how that worked.
Are there any inequalities in accessing these hubs that have been identified?
Well, as we've heard from adults that struggled to get access to healthcare for long COVID, the same, if not worse, is mirrored in the literature for children, trying to, with adults, with their parents, trying to seek healthcare, that apparently it was very difficult.
Can we move now to consider research into long COVID treatments, starting with the funding position? By way of headline, at paragraph 10, you explain that at the time of writing your report, more than £50 million had been invested in long COVID research projects in the UK. But, and this is at your paragraph 114, dedicated funding for long COVID research ceased after February 2021. Is that a fair summary of the position?
It is. The UK should be very proud of the research that it's done with acute COVID, and with long COVID research, the funding in the UK, and importantly, the discoveries that were made in the UK have really been world leading. So right at the very beginning of the early period post-pandemic, the UK had actually performed very well, and the early funding of that 50 million supported 19 projects through a core, as well as some additional projects that were really looking across the breadth of long COVID. So we started well.
We started well, and then what happened?
So the challenge to me really is that the problem has actually continued, such that you then need to have further understanding around mechanisms, around potential diagnostics, so leading you on to treatments. And other countries have recognised this. So in contrast to the UK, where the funding was very much front-loaded and, as you said, has then largely ceased about 18 months ago, the other countries really have then picked up. So in Australia, there was 50 million Australian dollars put into long COVID research just over a year ago. There's been now in excess of 100 million euros within Europe to fund a series of projects. And then from the US, which is really by far exceeded everyone else in terms of funding, has allocated over $1 billion in research funding for long COVID. So the way I view this is really the research for long COVID is very much a marathon, and the UK has won the first 400 metres, but is now paused.
Can I just check a date? I think Mr Mills may have put the funding ended February 21. Was it in fact February 23? Because you just said 18 months ago.
So the last funding call was in 21,
Right.
but some of the funding hasn't been increased but been extended. So for example, the funding for the consortium that we lead, FOSS COVID, has been extended through to 2026, but the original funding was right back in 2020.
What I wrote down, and it may just be I misunderstood the question, so I just need to. So initially, to the time of writing the report, what I wrote down, over £50 million invested in research. What I then wrote down, and it may be that this is where I got it wrong, but ended in February 21.
If it helps, Professor, I'm at your paragraph 114.
Thank you, that might help me.
Last sentence. Despite this, dedicated research funding for long COVID ceased after February 2021.
So the last call was July 2021, which was the last funding round, which was then the funding before that was February 2021. So it's July. So then looking at section 9, this is where it's correct if that's a misrepresentation in that sentence. So the funding that then came through from NIHR to fund 15 new long COVID projects was July 2021.
I see.
Oh, sorry, it's me. I mean, funding ended sounds like no more funds after February 21, but that's not what you're saying.
That's the award.
That's the award, okay.
That's the award.
So no more awards after February 21.
Correct.
But the awards that have been made up to February 21 could then be drawn on thereafter.
Correct.
Sorry, you wanted to add something, Professor?
I was just going to add that there were just very small amounts that were given to certain studies for legacy funding, as Chris was saying, for FOSS COVID, but it was very small. So the two calls were announced November 2021 and February 2021. They were the 50 million.
And they are then there for people to draw on when they're...
So typically the funding periods would have been for 2 or 3 years.
Right. You're obviously used to all this funding.
Sorry.
Mr. Mills, sorry to interrupt. I just want to make sure I got my facts straight.
Not at all, my lady. Can we think about pharmaceutical treatments? Are you able to share today any results we have from clinical trials of pharmaceutical interventions for long COVID?
So if we think about the trials that have really focused on this, so in the UK, it's been the Stimulate ICP study, which is not yet reported. So they have focused on really 3 avenues. So one is trying to tackle the problems with the autonomic dysfunction with antihistamines. with the activation of the lining of blood vessels with an anti-clotting agent, and then also an anti-inflammatory colchicine, but that's not yet reported. In the US trials, they have a combination of drugs, pharmacological and non-drug, non-pharmacological trials. And with those, they've been looking at the viral persistence with Paxlovid. Importantly, Paxlovid really focuses on replicating virus. So if you have a reservoir of virus, then treating it with Paxlovid may be less effective than some other antiviral approaches. I think that even if that reported as negative, it still wouldn't exclude that as a possibility. And they're also then looking at drug interventions to try and then modify sleep. There have been a number of small studies which have then been encouraging to then be able to take on larger interventions, but none of those have reported in sufficient numbers to yet have therapies that are licensed for long COVID. One of the most promising approaches is also to think about what I would describe as a precision medicine approach. And what I mean by that is if you can identify the underlying mechanism that's driving long COVID with an individual, you can then have a test that can identify that individual and then a treatment that then can then target that particular mechanism. And one of the ways of doing that is to then think about, is there viral persistence? Are there particular inflammatory pathways? Are there then problems around autonomic dysfunction? Are there then problems around the risk factors? And you can identify individual tests that map onto each of those. And one such study that's taken that approach is then targeting a particular inflammatory substance called IL-6, which was found to be really important in acute COVID. And you can target that with an injection treatment, and that's a study called FOSBI that Rachel's leading on and may wish to comment on as well.
Yes, so the FOSBI study we started earlier this year, trying to think of the date then, and we're still in a recruitment phase at the moment. And to really highlight what we've really needed is those long COVID clinics that are specialist clinics to get the right patients and to be able to have those linked with a research centre that is capable of delivering a very difficult experimental medicine trial. So it's a really good example of what we were trying to state yesterday. It feels like yesterday, earlier this morning, about the need for the long COVID clinics, because it's been absolutely essential to deliver the trial.
Moving on to non-drug treatments then, at paragraph 63 of your report, you observe that there are tensions around the use of physical activity in long COVID rehabilitation programmes. Could you tell us about that, please?
Absolutely, and it speaks really to what we have as a fairly simple definition of long COVID, whereas it really is a very complex condition, and it is made up of lots of different types of condition with different types of symptoms. And just like Chris was highlighting the need for a precision medicine approach for medication trials, the same is very likely to be needed for trials of rehabilitation. So the tensions around physical activity is that for any of us, we need to be physically active. That's good for long-term health. It prevents the development of long-term conditions. So all of us need to be physically active. Of course, long COVID with the fatigue and all these difficult symptoms impair physical activity. The rehabilitation interventions are really for healthcare professionals and the people living with long COVID to work together to try to improve physical activity with the aim of improving symptoms. For many people, that's a very successful approach. But there is this subgroup of people with long COVID with this really challenging symptom of post-exertional symptom exacerbation where we really have to be careful. It doesn't mean that we don't deliver any rehabilitation, but it has to be personalised. It has to be at the right time, and I don't think we know that for everyone at the moment. When somebody's got that really fulminant fatigue, they can't even really move around the house, they're getting crashes, that's not the right time for these interventions. So it has to be, at the moment, very individually judged, and we would like to get to the point where we've got research trials that really highlight who and how we should do this. So the tensions are that we've got this very careful balance between all of us wanting to improve physical activity, but how do you do it? And it's this balance between pacing and actually then progressing what someone's doing. And that has to be incredibly carefully done with experts.
I wonder, could I ask you to just introduce us to the concept of pacing for managing someone's long COVID symptoms?
Yes, and this is a technique that's been used for decades in other long-term conditions and another post-viral syndrome, so it's been used in HIV in particular. The aim is to understand that everyone's got a certain amount of energy, and this becomes very clear in long COVID, and that energy can be used in a physical task, an emotional task, or a concentration task. So pacing is how to use the energy for things that people want to do or have to do, but then to almost get some rest back to actually reset and not trigger that fatigue.
Can you tell us about any other rehabilitation interventions that are currently being used or being considered for use?
Yeah, so rehabilitation is an incredibly broad term, and I was talking earlier really about exercise-based or physical activity-based interventions. So there are a number of randomised control trials now that have read out this year that overall give very positive results of the type of programme where you have this close working with a healthcare professional and the person, and then progress the physical activity and symptom management as you go through the course in a personalised way. Other interventions that are being used are pacing and also with a little bit of progression. Those trials are still ongoing. There's trials of breathing techniques and respiratory muscle training. They've also shown promise. So there's a number of trials that are ongoing at the moment. Some have finished with positive results and some are ongoing.
Is there a trial also around sleep?
I think in the...
So if I can comment on that. So the NIH Recover, so this is in that very large funding tranche in the United States. They then have both pharmacological and non-pharmacological interventions for sleep. So it includes drug interventions such as melatonin to try and then reset the body's clock, and also then cognitive behavioural type interventions. There's also within the NHS Sleepio, which can also be accessed as a cognitive behavioural tool for then trying to manage sleep.
If we take everything we have discussed about this topic together, are there any areas of research focus you would recommend today to advance the treatment of long COVID?
So I think what we really need to have is a group of platform trials. So what I mean by that is the Stimulate ICP was focusing on repurposing therapies that are already available for other treatments and are largely low cost. But we recognise that there may be a need to have more specific therapies for certain types of changes, particularly changes in the immune system that we are now recognising in subgroups of people with long COVID. So to do that, you need a trial that's established where you have common entry into the trial, common outputs in terms of then the way we measure how well has somebody has done, and then individual arms so that you then identify the patient that's likely to respond to an intervention, and then put them into a trial where it's tested against a placebo, so a randomized controlled trial, but within a platform. And one of the things that we will be trying to seek is support from NIHR and UKRI. We had asked for support for a platform trial now a couple of years ago, but things have really moved on in terms of our understanding and the science and what endpoints to have. So we should be asking again for support for such a trial. The arms themselves may need support from industry as well. And when I've had discussions with industry, some of the companies are still looking to support trials within long COVID. But the story in industry is very similar to the story we were telling around the clinics, in that during the pandemic, there were COVID groups that were formed in most major pharmaceutical companies that were interested in both acute COVID, but were also thinking about therapeutics for long COVID. And those groups have almost entirely now been disbanded and gone back to their individual therapeutic disease areas. So actually getting support from companies is also challenging. We have had some traction, and I think we are in a position soon to then be able to then go back to government funding through NIHR and UKRI for such a trial, which would complement the activity that then is being done through Stimulate ICP and complement the non-pharmacological interventions that we've just been discussing.
New topic, please. Long COVID treatment and health inequalities. Before we consider what you are able to say about inequalities in long COVID treatment, can I perhaps invite you to set out the factors that limit our current understanding of this area?
Yeah, I think one of the major, if not the limitation, is data, and that data being from routine clinical healthcare records. We rely on that a great deal from UK to understand how healthcare is delivered, but it absolutely relies on people having a correct coding in their healthcare record. We've already heard that there's difficulties seeking healthcare, difficulties getting the diagnosis, difficulties with the terminology, and we just don't have enough people still in 2024 that have long COVID actually having the long COVID code on the database. That then means that we can't search, because to really understand healthcare inequalities, you really need to understand the prevalence to be able to do large-scale comparisons around how different demographic factors are actually affecting healthcare and the condition itself. I'm talking about needing good quality epidemiological studies, and that's what you need the data for. So that has been really limited. NHS England were keeping a good record of who was being seen in the long COVID clinics, so at least we had some idea of the demographics of the people that were actually receiving care through the clinics, but I don't think we have that any longer. And the whole thing after 2021 became even more challenging after routine testing reduced, because at least if you knew roughly the incidence of the infections, you could understand roughly what you would expect the prevalence of long COVID to be in certain areas. But without that, it's really difficult to actually understand what the gap is, to understand where the problems lie.
Please can we go on screen to INQ 000 421758. Professors, you'll recognise this. This is paragraph 88 of your report. We have data here collected by NHS England from July 2021 to July 2022 of the demographics of adult patients attending long COVID clinics. What does this list tell us about inequalities in the context of long COVID treatment?
I think there's going to be limited interpretation that we can really draw on this. However, the gender balance or the sex at birth balance between females and males is probably where you would expect it to be. The difficulty is that 20% of people seem to be missing their ethnicity data, and we just don't know for a fifth of people what is their background ethnicity, and therefore we really can't comment whether that data is really representative of our general population. Our suspicion would be that it isn't, and I think those of us running long COVID clinics think that there are definite people that we're missing, and they are people that we miss in all healthcare.
It sounds as if this tranche of data is indicative of the problematic global picture you've been describing.
Absolutely.
Can we next go to INQ 000319639? This is an extract of the statement of Caroline Abrahams of Age UK, who the inquiry heard from yesterday. I'd just like to look at the first sentence of paragraph 79. There may also be under-recognition and under or delayed diagnosis of long COVID in older people whose symptoms, including problems with balance and mobility and chronic fatigue, may be written off as age-related. Is this a concern you recognise?
Yes, absolutely. And that probably happens on an individual level where people start experiencing things and they put it down to their age and delay seeking healthcare. And then healthcare professionals as well, if they're not clued into long COVID, could absolutely underestimate it. I would also say that the flip side is very true, though, that in the clinic, we also concerned if somebody's presenting with long COVID and memory loss, we absolutely don't want to assume that that is all long COVID if there are potentially reversible or treatable conditions. And that's why you need these specialist clinics with those MDTs. So this is exactly the type of problem that we discuss.
Thinking about a different cohort of individual, at the start of your evidence, we explored healthcare workers as being at higher risk of developing long COVID during the pandemic. Can you help the inquiry understand what can be done to support healthcare workers with long COVID to return to work?
Yeah, absolutely. There are a number of challenges for healthcare workers, not least that many of them did contract the virus during their day-to-day work while trying to help people. The things that we need, their general care will clearly be the same as for somebody else with long COVID. But as an organisation, I think the NHS needs to really support people returning to work. The vast majority of people I see actually try and return to work too soon, that it is the thing that is prioritised over everything else. So even though they can barely do something, they're telling you that they're still trying to get to work. One of the things we've really learnt around that we've all needed really good links with occupational health, and the occupational health teams on the whole have been very proactive to understand about long COVID to help their the people that they're trying to help, meaning more broadly. Within the NHS, we have very fixed phase returns. There's a process and it's very rigid. And a common theme that you're hearing today is how long COVID is not fixed. It is incredibly variable, changeable, and the fatigue really needs a very carefully planned, flexible phased return. So the NHS can do a lot better to facilitate that. And the vast majority, I can just speak from personal experience, the vast majority of healthcare workers, if not all of them, want to get back to work. That is their goal.
at your paragraph 92, you say that proactive care could improve health equity. Can I ask what you mean by proactive care in the context of long COVID?
Yeah, absolutely. This, it's relevant for all long COVID, but it was particularly relevant for the people post-hospital. So many people, obviously hundreds and thousands of people or hundreds of thousands now, came into UK hospitals with this lung infection, very typically. If we just leave follow-up care, if they're discharged home, and then we just leave follow-up care for that individual to then initiate coming back into the healthcare system, they would face exactly the same issues as we've heard from those non-hospitalised. With proactive care, it means actually that you have the cohort of people that are admitted to hospital and you ask all of them whether or not they're fully recovered. And we've actually managed to do this locally using an automated AI system, because obviously we want to target services to where to the people that haven't recovered. Our early data from the FOSS COVID study did show that actually 70% of people are not recovered by 1 year. So actually you're delivering proactive care where the majority of people are going to need care, and you're trying to just ensure that everyone is not left to their own devices to seek healthcare. Healthcare inequalities come in when you've got different healthcare seeking behaviour. It's much more difficult to implement something like that at scale for the community, just because 95% of people will thankfully recover from COVID-19. But we definitely need, going forward, need to think we've got very sophisticated tools and technology. There must be a way of being able to proactively reach out to people that have not recovered and therefore reduce the burden really on the individual to do all the healthcare seeking themselves.
Both in your report and in evidence you shared earlier today, you have compared the rapid development of care for acute COVID-19 with the comparatively slower development of long COVID care. In your view, does this reflect a common disparity between acute care and chronic care?
It does, unfortunately, where healthcare does seem to be highly prioritised to acute care. And I'm not saying I want to take anything away from that. But we need to have equal priority to people living very difficult lives with long-term conditions. It is not seen anywhere near as much as acute illness, both in the public and the healthcare system.
I'd just like to add that the timing is different as well. So this doesn't have to be done at the same pace and scale, because we know that the main problem at the height of the pandemic was the acute problem. People were dying. So clearly having a very well structured acute service and research that was then identifying therapies in the acute setting was entirely the right thing to do. Identifying a vaccine was entirely the right thing to do. But the problem that we've seen is that there was some initial investment that was done quite slowly for long COVID, and that's neither been sustained nor accelerated, in spite of the fact that this is still a major problem.
Can we turn now to your lessons and recommendations? I'd like to approach it in this way, please. First, we'll look at your recommendations for how to diagnose and treat the long-term consequences of a future pandemic pathogen. And then we'll look at recommendations you have about the treatment of long COVID. So, the former, as far as you are aware, does the UK currently have a plan in place to address the long-term consequences of a future pandemic illness?
So within the UK, there is some funding that was already in place ahead of COVID-19 for pandemic preparedness. But the magnitude and scale of this funding is really very small. So what it allowed them to do was to develop what we call a hibernating or a sleeping study for looking at the observational study to try and follow the pandemic in its early stages. And that was the ISARIC study, which was very successful. So it was very successful at them being able to start to understand what does the acute pandemic look like, what are the at-risk groups, and be able to give us those early demographics and early epidemiology. It's a big success in the UK and UK-led. But we didn't have that for long-term conditions, and as far as we're aware, there still isn't in place a plan for a similar event in the future that may then lead to long-term conditions. And yet, as we alluded to early on, we already knew from other coronaviruses, so with SARS-CoV-1 and from MERS, that there were a high proportion of patients that then developed long-term consequences. Unfortunately, those conditions did not have anywhere near the number of people that were affected, so it didn't have the same global impact. But it only has required this breakthrough virus with COVID-19 to then really reveal just what an enormous problem what is now called long COVID has really been, and any other post-infection consequences in any future pandemic. So there clearly does need to be some preparation, which could include hibernating studies for research, but also thinking about the clinical models as well, as we've already discussed, with an expansion of the existing clinical service. That could itself, or it could be in parallel, an activity to also then have preparedness for them being able to accelerate at scale new clinical services at the point when there's a new pandemic. So I would hope that there are positive things that can be a legacy from this pandemic.
Anything you would add to that, Professor Evans?
No, I don't think so. Thank you.
Turning then to your recommendations for the treatment of long COVID, can I start with this, please? In your view, is the future planning and resourcing for long COVID care adequate?
I don't think so, not from what I'm seeing. I think I would have answered this quite differently last year. I've been trying to sort of reflect on that. And I'm really concerned that the expertise, the clinical care that was set up in England, that, as Chris has said, should have been accelerated, has really reduced. And I am concerned what it's going to look like a year from now, when it's more business as usual in the integrated care systems. And we absolutely understand that the NHS is under extreme strain, but it is absolutely our job to highlight this condition and highlight the need that these specialist clinics and the long COVID care, both primary care, community care, and then the specialist clinics and interventions, needs to be continued. The ONS data from 2024 clearly shows it's not going away.
One thing that really worries me is how all of the voices that we hear from the patients' testimonies could end up falling silent, because if the clinics slowly start to evaporate, the expertise is not kept and expanded, you then have a situation where patients then don't have a service to support them, and they're then just falling into whatever the local system is that is currently there, which is very likely inadequate. And that in many ways means that, in sort of perversely, the problem seems to go away, because then you're not actually seeing the condition, because it's no longer visible. And to me, that would be a real travesty. And I think we're at a tipping point, really, where there's a real opportunity to learn from what we have already achieved, and to really then build back up the services, maintain them, develop expertise, identify new diagnostics, new therapies, and actually make really big strides. But in contrast, there's a risk that these things will actually fall to one side.
In respect of prevention, at your paragraph 125, you highlight the role that vaccination can play. Is there evidence that vaccination has an impact on the severity and incidence of long COVID?
Yes, absolutely. And this is now through a number of different studies that show that people that are fully vaccinated are at less risk of getting long COVID, and those that do overall, and again talking in cohorts, overall they have less severe long COVID. Yet the at-risk groups of getting long COVID, and of course someone that's already had long COVID would very much be in that group, never seem to be on the at-risk group for vaccinations. They are still very much geared, and again this group should be included, to the older population that are more at risk of the acute illness and of course mortality.
You've referred both in your report and earlier today to the importance of training healthcare professionals. And at your paragraph 129, you note the importance of providing occupational advice to patients and vocational rehabilitation. I wonder whether you could explain what those two concepts mean in the context of long COVID.
Yeah, absolutely. So we had, and we've not really discussed them today, but they're in the report. We have existing rehabilitation programmes for lots of different long-term conditions, but actually they tend to be on the whole for older populations, and the vocational aspect of rehabilitation really hasn't particularly been included. Certainly for long COVID, this is largely a working age population that want to get back to work, and vocational rehabilitation is really the way to do that it is very focused. You've got the right experts within that MDT with a very different skill set to the other healthcare professionals, and the whole target is about how to help people to get back to work. And they are also critical link back into the occupational health role to then support the organisation that the person's working in to actually have that real phased return that's personalised and actually going to help people return to work. And that's good for everybody. That's good for the individual, and it's certainly good for the healthcare system to have our healthcare workers back into the NHS.
Throughout your evidence, you have made certain recommendations as we have progressed. Can I finish then with this? Are there any other recommendations for the future of long COVID treatment that you would like to share with the inquiry?
I think I'd simply like to say that this isn't fixed. It hasn't gone away. And we really have made quite phenomenal progress in a short space of time, such that we're ready now to move into further treatment trials to then try and then underpin the clinics. And it's just critical that that's supported and accelerated and not undermined.
Professor Breitling, Professor Evans, thank you. My lady, that's all I ask.
I was thinking of breaking now before I ask Ms Hannett to ask her questions. So I'll break now, 2:45, and come back at 3 o'clock.
All right.
Last leg, professors. Ms Hannett, it's over behind you, back to the right.
My lady, thank you. Professors Breitling and Evans, I ask questions on behalf of the long COVID groups. I'll direct questions to both of you, but as with Mr Mills, do please answer as you feel appropriate. And I should add, we're very grateful to Counsel to the Inquiry, who has put a number of the questions to you that we intended, so I will cut my cloth accordingly. Can I start, please, by asking you about paragraph 3 of your report, where you state that since writing the Module 2 report, long COVID remains a significant health priority. Please, can you explain in a little more detail why you consider long COVID to be a current and ongoing significant public health priority?
Yes, of course. So it is a significant and ongoing priority, both in terms of volume of people affected, as to repeat the ONS figure that 2 million people living in the UK currently are estimated to be living with long COVID. And also, it's an absolute ongoing priority for the people that have been severely impacted for the condition, and the need for both research and clinical care to be continued.
If I may, I'll add a couple of extra dimensions. So not only is it clearly of remaining importance for the individuals who are suffering, but it also has an economic and societal impact as well. So the estimates just on loss of income is in the order of $1.5 billion, according to the Institute for Physical Studies. And then there's been estimates of the overall cost based on the clinical healthcare costs, the carers' costs, and the other socioeconomic costs due to loss of earnings. And it's been estimated to be somewhere in the region of about 0.5 of the UK GDP. So I would have thought the day before a budget that actually taking into consideration not just the personal impact, but the societal impact and economic impact is really important.
Thank you. I'm going to turn to ask you about access to adult long COVID services. You've given evidence already about the difficulty and delay for patients in accessing services in all 4 nations, and that reflects the experience of members of the long COVID groups. In relation to long COVID services, long COVID care currently comprises both rehabilitation and clinical management of long COVID. Are rehabilitation services without some form of clinical management of long COVID symptoms sufficient to care for all long COVID sufferers?
I would say no. I think there's that tiered approach and stratified approach to clinical care. So a light touch approach for some, definitely having that multidisciplinary team and rehabilitation service, but I believe you must have medical oversight of these services so that you can ensure that first part of the journey, getting the diagnosis right, answering people's questions appropriately. They have individual questions about individual symptoms. They must have time with somebody that can answer those as best they can. And where it's unknown, have trust that the person that's just saying, actually, at the moment, we don't know, that really is the best answer. But I do believe they must have medical support. That multidisciplinary team that we talk about needs to have medical staff involved.
And assuming that there's a medical staff present, what other different professional backgrounds or different types of healthcare professionals, what impact can they provide on the quality of the care that can be provided?
Absolutely. I think it is so important that there is one professional that really is taking control of the person's care. And then absolutely need a range of specialists to help support that care. And that doesn't mean sending somebody off to multiple specialist appointments where they're going to hear different views, different focus, and have to spend time and money and energy doing that. It is much more efficient for everybody, both the individual and the healthcare system, to have these clinics with relevant expertise. And that now we probably know more than we did in 2020, 2021. Certainly the MDT that I run has changed quite significantly over the 4 years to learn which specialists we really need. Locally for us, that's cardiology, respiratory, neurology, rheumatology, liaison psychiatry, mental health support and rehabilitation, the suite of the multidisciplinary team that you need to deliver the interventions.
And just by way of follow-up, in your experience in terms of the long COVID clinics that are available in England, is the type of multidisciplinary care that you've just described that you deploy replicated in all of the long COVID clinics in England?
So I would say at the beginning, going into 2021 was probably our sweet spot of getting things as good as it's been. There were several clinics that looked like that. I'm not sure ever the 100 clinics that we had, but we were working towards there. And actually there have been really good examples of peer learning within clinics where you can share good practice. That was and patients were absolutely key to that. That worked very well. Now, I think we're really running the risk that actually those clinics are few and far between, and actually those clinics are then getting really stretched. You're then not being able to deliver care in a timely, effective way. So as we were saying before, we really need to advance this, not be in retreat mode.
Thank you. Just then looking at long COVID services for children and young people, can you expand a little more on why you recommend a dedicated long COVID multidisciplinary team to provide support for children and young people?
Yeah, absolutely. In a similar vein to adults, and absolutely children and young people can have different symptoms and manifestations of long COVID to adults, but the principles of care should be the same. And actually, just like we were talking right at the end about occupation and vocational rehabilitation, actually working with schools and education is such an important time in a child's life, often going to school and education, to have that actually interrupted for a month, let alone many months and maybe a couple of years. Really need those clinics to have that expertise to support the wider social support needed for children.
You perhaps may have already covered this, but just for clarity, can you comment on whether general paediatric services are sufficiently well equipped to respond to the needs of children with young people with long COVID?
So I'll answer that with a caveat that I'm not a paediatrician, but I can't see why it would be different. In fact, I would say it was probably more important that you had dedicated specialists for children. So just like I wouldn't advocate that, and actually there very often isn't generalists as such, that specialists tend to have their own specialty, and then I think you'd be at risk of the same repeating multiple appointments and not actually ever getting a solid answer or a solid plan.
Thank you. Then just moving now to healthcare and treatment. You've given evidence on post-exertional symptom exacerbation. Do you agree that advising long COVID sufferers to participate in graduated exercise can exacerbate long COVID symptoms?
So I agree that exercise at certain times and in certain individuals can be extremely challenging. That everybody needs to be assessed, and then again, as part of that complex assessment, post-exertional symptom exacerbation is one of those things that need to be explored. The exercise rehabilitation that we're advocating, that is being used in clinical trials, is this personalised approach. So it's not a fixed regime, it's personalised to the individual with pacing and progression, working with the individual person. That's definitely what we would advocate.
And would you recommend that advice on PESC, or post-exertional symptom exacerbation, is included in the NICE guidelines on managing long-term symptoms of COVID-19 to prevent medical professionals providing potentially harmful advice on exercise?
Yeah, absolutely. It needs to be incorporated both in terms of definitions and in clinical care, and it would be one of the phenotypes that that future research trials should actually distinguish even further.
Can I just add a further comment, though? So in the ME/CFS diagnosis, the PESI is part of the definition, whereas with long COVID, it clearly is recognised as being really important in some individuals, as Rachel's explained. So I agree should be part of the guideline, but not necessary as part of the definition of the diagnosis.
Understand. And just while we're talking about the NICE guidelines, they haven't been updated since November 2021. Apart from PESE, are you aware of any other significant developments in the understanding of management of long COVID which should now be reflected in those NICE guidelines?
I think there's certainly enough learning and clinical trials that have been conducted that another synthesis would be timely. And I think that, as we keep saying, that if you've got clinical care and experts in the field, then you will promote needing these guidelines. One thing I do want to highlight is, on a much more positive side than perhaps we've heard a lot today, is that we're really in a good position because of the long COVID advocacy groups, long COVID support, long COVID SOS, long COVID kids. I think actually we've taken a lot of learning about how to work with people living with the condition, both in terms of research and in clinical care. So for future guidelines, we're already planning how we can work together and whether that's NICE or a different organisation, to actually synthesise what clinical care and current research looks like.
Thank you. Just moving on to research in long COVID, you've obviously discussed two buckets of government funding for research into long COVID, one in autumn 2020 and the second in spring 2021. Just looking backwards, first of all, can you comment on how the speed of approval and funding for research into long COVID compared with the speed and funding for research into treating acute COVID, and whether there's any justification for the distinction?
So there's a number of differences that I think are worth pointing out. So the speed in terms of the decision making for the funding was actually faster than you would typically have within normal funding rounds, but much slower than was done for the acute episode. What was perhaps the greatest problem was actually when things were then supported, that there was a major problem in terms of the research governance in the UK. So one example of that would be the MHRA, who are clearly have to be involved when it's a investigational medicinal product, as was the case with Stimulate ICP. So you then end up in a situation where the funding is awarded, but there's a very large delay then from the point where funding's awarded to then actually be able to start the trial. And the same was true for Rachel's study that she described earlier, FOSP-I, where there was almost a year from the initial applications for all of the approvals, because at that time there was a real problem with the MHRA governance processes. This is now much better, but it did impact particularly adversely on long COVID studies at a time when you wanted to be able to move things very quickly. Some of the studies became very slow. In contrast, FOSP-COVID, which was the study that we co-led, was actually approved and patients were then recruited very quickly. So the point from approval to an ethical approval was a matter of days, and then first patient was a matter of weeks. So it showed that at the height of the pandemic, things could be done at incredible pace, which was not the case with later studies.
You were asked all the questions we were going to put you about research in adults, apart from the one I've just asked. But could I just ask you about research for long COVID in children? Has there been any biomedical research to better understand long COVID in children and young people? So there is work that's particularly focused now through the NIH Recover programme. In the UK, there's very limited research in terms of then looking at the underlying biology in terms of then doing sampling, but considerable work in terms of then looking at the epidemiology and the phenotyping, so the description of long COVID in children and young adults. And in your view, would that be a recommendation that you would make, that sort of work ought to be carried out in the UK? So I think there needs to be a suite of research. So we talked earlier about the types of approaches that we would recommend in terms of intervention trials, but also the more fundamental understanding should be supported through particularly
through UKRI in the UK, and that would allow for more discovery research, which would include children and young people as well as adults.
Penultimate topic, data and long COVID. You gave some evidence earlier about the quality of the data in the long COVID clinics. We've also had evidence earlier in this module about long COVID coding in primary care, and I wondered if you were able to comment on the quality and the accuracy of that coding.
Yes, I commented earlier that it's been a real issue around getting data at large scale using electronic healthcare records because of the poor quality of coding. And when electronic studies have reported on long COVID, it really does underestimate the prevalence of long COVID and the impact.
And that data then, I think by implication you're suggesting it should be collected. How should that situation be improved in terms of collecting the data to enable your research and so on?
Yeah, it's a really good question, and certainly early in the pandemic, there was a lot of work done actually led through the Royal College of General Practitioners around coding for long COVID, but for whatever reason over the last few years, it's still very much underused.
And in terms of, that's prevalence data, in terms of impact of data on the impact of long COVID, i.e. the impact of its severity on sufferers, should that also be collected, and if so, by whom?
Absolutely, and that's also really missing. The ONS team did a really good job, and again, I know that patients living with long COVID very much were involved in that survey to make sure that the impact on daily life was recorded. There have been, they're very crude, but it's a good guide, is the COVID functional scale, and I think we should be using that in primary care and secondary care. It's a 1 to 5 scale, very similar to we use for breathlessness for certain long-term conditions, and actually they tend to be, and certainly the evidence so far shows that scale is quite good at highlighting who's got the worst impact for health-related quality of life. Obviously, occupation can be assessed. The problem with returning to work is that some people return to work even though they're not able to really fully engage, or they've got no other life apart from doing that. So again, that's a crude way of measuring impact. With the scale, that can then be used to prioritise, when I keep saying about stratifying care, actually those in the sort of 0 to 1 categories then can have a light scale approach. Those that are more heavily impacted, they would be a really good guide for GPs to think, yes, that's who I need to be referring on to specialist care.
Thank you. Last topic, public awareness on long COVID. Given evidence on the current risk of developing long COVID from new COVID-19 infections and reinfections, and Professor Evans, you gave evidence just now on the need for those with long COVID to be prioritised for vaccinations. Can you just explain why that is important in the context of reinfection?
So, generally, vaccination has a protective effect to getting long COVID. Even if we don't understand all the mechanisms of why certain individuals get long COVID, there are absolutely individuals at risk. And we have to start thinking that, and because infections are still common, they're still out there in the community, SARS-CoV-2 hasn't gone away, if you were susceptible to getting long COVID, whether that was your personal demographics, something in your immunology, whatever it was, surely you must be at risk of getting it the next time. And therefore, if you've already got a condition, you definitely don't want to get it again and get the condition worse. So that's what I was basing that comment on.
And does the same point apply to the lack of eligibility for children and young people for vaccination?
I don't think I can comment on that just because I really don't have the medical knowledge.
Understand. I'll move on to my next question, which is, can you advise on whether there are sufficient public health communications, if any, on the current risk of long COVID in the context of the ongoing transmission of COVID-19?
Can you just repeat the first
Of course,
part of
but
that?
simplify.
Sorry?
Are there sufficient public health communications on the risk of developing long COVID, given that the COVID infections are all around us still?
Again, it's a really good point that actually all the way through the pandemic, we naturally had the statistics from the hospital admissions, the deaths, but actually at no point did we ever really get in the public eye the volume of people with long COVID nor the impact. And actually, I think the public are largely still unaware of the potential longer-term consequences of getting the virus and reasons to avoid it.
Thank you, Professor Evans, Professor Breitling. Thank you, my lady. Those are my questions.
Thank you, Ms Hannett. Ms Peacock, who's behind you, if you could make sure, please, that your answers go into the microphone. Thank you.
Good afternoon. I ask questions on behalf of the Trades Union Congress. My questions relate to the impact of long COVID on Black, Asian and minority ethnic healthcare workers. You've already been taken to paragraph 88 in your report, which sets out the percentage statistics on ethnicities of patients who accessed the long COVID clinics. Professor Evans, you helpfully explained that there is missing data on ethnicity within those percentages and missing data in respect of those who may not have accessed the clinics. Do you consider that long COVID disproportionately impacted, both in terms of prevalence and severity, upon Black, Asian and minority ethnic healthcare workers? Or perhaps my question is, do the data exist for you to answer that question?
Yeah, I was, before you put the caveat in, I was about to answer. I think, unfortunately, we just don't have good enough data, and we urgently need that to understand, even in the clinics we've got, who are we actually missing. And because long COVID is a symptom-based condition, it absolutely depends on language and understanding, both for the person themselves, if they've got the condition, to know to access healthcare, and then for healthcare professionals to be able to interpret that. And even with the research, and this has been written about, even the way that the outcomes that we use, they all need to be culturally sensitive. So there's a whole host of research work that needs to be done there, and what we need to do in clinical care to really be able to understand how long COVID is affecting different populations.
And just focusing on what we do know, the data which are available, I'd like to briefly identify two passages in your report which you've already touched upon in evidence. First, at paragraph 87, you note that long COVID is more common in females, middle age, pre-existing health conditions, including obesity and social deprivation. It's also known that female sex, obesity, and pre-existing health conditions make someone more likely to develop severe long COVID rather than milder disease. And then secondly, you explain at paragraph 94, healthcare workers were at higher risk of exposure to SARS-CoV-2 infection throughout the COVID-19 pandemic, and early studies highlighted the risk of severe disease associated with certain ethnic backgrounds. In absence of clear data and just taking what we do know, given the higher incidence of COVID-19 infection in healthcare workers, the higher prevalence of pre-existing health conditions in Black, Asian and minority ethnic groups, the higher prevalence of severe disease from COVID-19 in Black, Asian and minority ethnic groups, the higher level of vaccine hesitancy and refusal in those groups, in particular Black, Pakistani and Bangladeshi groups, and the higher levels of social deprivation associated with structural racism. Is it fair to say that the data we do have give rise to a real concern that long COVID may disproportionately impact Black, Asian and minority ethnic workers?
Absolutely, and I think it's that impact not only in all ways, in how people then access the healthcare. There's been some very specific qualitative work, which was actually a very difficult read, which was highlighting the challenges that people from different backgrounds have, both with experiencing long COVID and then seeking healthcare support. And their voice would definitely say that there are issues there that we urgently need to address.
Studies are ongoing to understand the potential disproportionate impact in the way that we've been discussing, and in particular the NHS Race and Health Observatory Reach Out study, which is in its third and final year as I understand it, and so far has published 2 interim reports. If long COVID is found to have disproportionately impacted upon Black, Asian and minority ethnic healthcare workers, what do you consider could and should be done in a future pandemic to avoid any such disproportionate impacts being repeated?
If I may, so one of the things that we don't fully understand until it happens is what the risk factors are going to be for a future pandemic. So I think what we need is we actually need those hibernating studies that we've described, the clinics that are ready to be increased at scale, but also recognition that there are groups that so far we've not I think served as well as we could for the reasons that you've described. That doesn't mean that we can assume that the next pandemic will disproportionately affect one predefined group versus another, but it's likely to be affecting certain groups, certain risk groups. And as long as we recognise that, and as long as we set things up in order to make sure that we are identifying that and acting accordingly, that to me is the real key.
So building on that lack of certainty that you've identified in respect of a future pandemic, the Chief Medical Officer who we've heard from, Professor Sir Chris Whitty, he gave evidence that in his view, the key to improving the safety of higher risk individuals was principally to optimise the safety for all in the workplace, so rather than sectioning out groups. Does that logic apply here in terms of disproportionate impacts of COVID-19 on healthcare workers, that perhaps prevention is the best cure and avoiding occupationally acquired COVID-19 infection for all workers would be the best way to approach the issue?
So on one level, I agree that obviously if you can have optimal management for all, then that would be ideal. But we recognise that there will be disproportionate risks, and for that reason, I would disagree with Sir Chris Whitty in that I would suggest that we need to not assume what those disproportionate risks are, but at least be cognizant of them, prepare for them, and then adjust and direct our resources in order to try and mitigate those risks.
So identifying those risks early and assessing based on them.
Correct.
I'm grateful. Those are my questions.
Thank you, Ms Peacock. Mr Stanton, who's also behind you, so I'm afraid test your neck muscles.
Good afternoon, professors. I ask questions on behalf of the British Medical Association. I'd like to ask some questions about the topic of managed returns to work, which is an issue you've already touched upon with Mr Mills. And the circumstances I have in mind are as described by Nicola Ritchie earlier in her evidence, particularly thinking about her fears for her ability to continue with her career. At paragraph 129 of your report, you note that flexible, individualised, prolonged phased returns appear to be better managed in the private sector than in the NHS. Are you able to provide any examples from both the private sector and the NHS to illustrate this difference in approach? And what do you think are the reasons for flexible phased returns being better managed in the private sector?
So those comments, I do need to caveat that they are my anecdotal clinical experience from having now delivered a long COVID clinic most weeks for 4 years. And I'm certainly not saying that everything in the private sector was better, but anecdotally, certainly in smaller companies, there just seemed to be better care, better links to occupational health, and a bit more listening and guidance, and probably just a bit more flexibility. It has felt that the NHS has this very fixed process, which we all understand a very large employer has to have some guidance. But there are pockets, definitely, of occupational health physicians that are desperately trying to learn about long COVID and work with the individual. But from my side as a clinician, I've just heard that feedback too often that I wasn't ready to do the whatever hours it was, this many weeks, the next time, the very fixed targets. And then people are, stopping working when they don't want to. And that, again, my opinion is that doesn't seem helpful for anyone. It's not helpful for the NHS and it's not helpful for the individual. And actually, as I've said before, I can't think of anyone actually that I've worked with over the last 4 years that hasn't wanted to return to work. So everyone's got the same goal. And actually with some people, we've had really good experience of really careful phased returns, different types of work for a period of time, some adjustment on the healthcare professionals, particularly front, that they might not be able to go and deliver exactly what they were doing before. And we've had some real success stories.
Thank you. In addition to the individual impacts of poorly managed returns, can you give some idea of the types of adverse impacts on the wider NHS and also on the quality of patient care?
Yeah, absolutely. It becomes a terrible storm where the figures from after the pandemic in the NHS of the sickness rates were extremely high due to, and we've heard in this inquiry from ICU, from other departments, just the trauma that people working in the NHS went through the pandemic. So there are higher sickness rates anyway. Some of that I expect is long COVID. So the organisation needs to support their healthcare workers to get back to work, to help the organisation as well as the individual. And at sickness absences in the NHS, the workload is already probably 110% of what you feel it should be. As soon as there's people missing, it just gets desperate. And unfortunately, the main people that are impacted by that are the patients.
Yeah. Is there also a loss of specialism as well, or a risk of a loss of specialism by not facilitating proper returns to work?
Absolutely. Certainly for healthcare professionals, there's been a huge amount of investment in training. Nicola, a very skilled physiotherapist, you don't want to lose that expertise. And I think perhaps as well we need to think about other when I was saying the flexibility of returning to work, proactively thinking, well, what other jobs could people do if they can't do exactly what they were doing before? Much more flexibility. And I think that's where I just felt it was very much a personal anecdote, having been in the clinic. I just felt that sometimes the private sector seemed to get that a bit better. And I suppose that was a bit shocking, especially as for healthcare workers, they certainly in 2020 had actually contracted the virus at work.
Thank you. Moving on to a slightly different but connected topic of early intervention. Can I ask, how can the NHS improve its early intervention and diagnosis of long COVID so as to minimise, where possible, the severity of the impacts that we've discussed, and also the wider societal impacts, such as the economic cost of long COVID, which you refer to at paragraph 38 of your report?
Yeah, that's a huge question. So to start with, as we've said, actually having a healthcare service and system that is long COVID ready, having the research to understand much more about this condition, having the treatment so that we can get the treatments in early, and that still needs a huge piece of work between clinicians, researchers, government, patients.
Thank you. And finally, a question about health inequalities, please. Having regard to your reference at paragraph 79 of the report that social deprivation is known to be a key driver of health inequalities and has been associated with a risk of long COVID, can I ask whether, in your view, the state is ensuring that resources for managing long COVID, such as specialised clinics and support programmes, are equitably distributed between poorer and wealthier areas?
So I don't know the facts for that, but I expect we're absolutely at the mercy of the inverse care law for long COVID. That, as I was saying before, the patient groups have had a huge role in advocacy, and I expect a lot of the clinics are in secondary care next to academic centres. And absolutely, we need to really re-look at where clinics are and to ensure that it's the right support into different communities.
And connected to that, and finally, at paragraph 85 of your report, you indicate that long COVID care is disproportionately accessed by people from higher socio-economic groups. Can you give any indication as to why that should be?
Yeah, so that comment was from the NHS England post-COVID hubs for children and young people. I think they were mainly just trying to highlight that even all the barriers that we've heard of again, how to actually access healthcare, how to actually then persevere to get through the healthcare system has been incredibly difficult. And it's likely to be those with more knowledge, more ability that are able to do that, and therefore is even worse for people that have got more difficult lives, different priorities, and we just need to make access easier for everybody, but ensure that we're not missing very important groups.
Thank you very much. Those are all my questions. Thank you, my lady.
Thank you, Mr. Stanton. Mr. Simblett is again behind you, but a bit closer.
Good afternoon. I'm asking questions on behalf of the COVID Airborne Transmission Alliance, or CATA. And it's in relation to what's in your report and your oral evidence in relation to dedicated long COVID clinics and rehabilitation services promoting a unified approach to long COVID care. And as you said earlier, clinics are a foundation for long COVID care, clinically effective, cost effective. So in that context, given, as you also said earlier, that there are worrying consequences for the ever-increasing disparity in long COVID care, would you go as far as to say that there should be statutory minimum criteria in relation to NHS long COVID services, and would they promote consistency in the service patients receive across the UK?
So the short answer is yes, and the NHS England service specification really did set out to highlight what good care would look like. I don't think I've got anything else to add to how you actually make that happen, but absolutely there should be a minute for a given population, having that tiered approach so that you stratify care according to the need. So it's not that I'm saying that everyone with long COVID needs that top-end service. That's not correct. But everyone with complex needs should be able to access complex care.
Thank you. I see Professor Breitling nodding. Is there anything you needed to add?
I think it's also important that the same equity of access is across all four nations.
Thank you. Those were my questions. Thank you very much.
Thank you, Mr. Simblett. And lastly, Mr. Thomas. who's going to come round to where Mr. Simblett was.
Good afternoon, professors. I'm representing FEMHO, the Federation of Ethnic Minority Healthcare Organisations. Can I first start with discussing the data and the limitations on the data? In your report, you noted the ongoing challenges in understanding the full scope of long COVID, particularly due to the limitations in the data related to ethnicity. Can you share any progress made in understanding how ethnicity may influence the risk of developing long COVID?
So you're absolutely correct. This is an area where it needs more work. So what we do know is when we originally recorded the ethnicity in the early studies, that there were certain risk factors that were coming through very consistently. So age and sex and comorbidities in particular. Whereas with ethnicity, I think the picture was much more complex in contrast to really the acute COVID, where clearly there was an increased risk. Whereas in long COVID, it seems that increased risk is less clear. And I think that's because of this poor data recording, exactly as Rachel's described. And I think that's what we really need to strive for. But your question was, are we aware of that actually happening? And I think we can say that amongst other things that we've listed, really is on the list of things that still need to really be done.
Okay. Professor Evans, I think you agree that the current data limitations continue to hinder a comprehensive understanding of disparities faced by ethnic minorities. Is that correct?
Can you just repeat the last bit? Sorry.
Yeah. In response to questions from Ms. Peacock just a moment ago, I think I understood your evidence to be that current data limitations continue to hinder a comprehensive understanding of disparities faced by ethnic minorities. Is that correct?
Absolutely. We just don't, both epidemiologically and in clinical care, we just don't have good enough data to really understand what the gaps are to then be able to think through the other questions of what we then do about them.
Which leads me on to my last question on this topic, which is this. What measures would you recommend to enhance the collection and analysis of data regarding long COVID in ethnic minority communities? And I take that feeds into what's just been said, but if there's anything else.
Well, I think it just needs to be really thought about carefully. That's the first thing. I think most of the long COVID studies that were set up did have that in mind. Certainly we can speak to the study that we ran. We were very aware that we wanted to make sure it was inclusive, that we got the right participants, and we did quite a bit of work to how to engage certain communities in research. And certainly in our institution, we have the Centre for Ethnic Health that does this, not for just long COVID, but actually trying to make communities almost research ready so that we make sure that we've got the research designed in a way to be inclusive and actually communities ready to trust and be participants in that research. So that's one thing. We've not talked much about outcome measures today, but again, a lot of our outcome measures for long COVID are around symptoms, around how people feel. We need to make sure that they are both language and culturally appropriate. And that is absolutely something that we can be working on in between pandemics. You don't need a pandemic to suddenly start being able to have appropriate outcome measures. So that's certainly not the whole package of answers to your question, but that's at least a couple of things that we should be doing.
That leads me very nicely on to the second area, which is addressing health inequities and cultural barriers in long COVID diagnosis. At paragraph 92 of your report, you mentioned that health inequities can arise from varying health-seeking behaviours. Question, to what extent might racism, stigma, discrimination and cultural differences contribute to these difficulties in recognising long COVID symptoms among the ethnic minority communities?
So again, very important question. I think the question around stigma and scepticism we've heard for all populations with long COVID. I mentioned a study that was very uncomfortable reading, which was a qualitative piece of work where they went out and interviewed people with long COVID from different backgrounds. And absolutely the patient testaments there is they do feel that all the things that you've listed there have been for a greater or a lesser extent experienced by some patients.
What improvements could healthcare systems make to ensure timely and supportive diagnoses for long COVID within these communities? So I'm trying to look forward and in a positive way. What could be done?
Absolutely, and I'm trying not to steer into the whole population, but there is so much work that we need to do that really accounts for everybody. I've already just mentioned about the work that the Centre of Ethnic Health are doing. I can't think of anything else.
I think one of the things that Rachel alluded to earlier, which I think is where we perhaps need to go, is also that early case identification. So at the moment, we're very much relying on a reactive process with what we've already described really as an inadequate national service for long COVID. Whereas what we actually need to do is recognise what are the key presenting symptoms, what are the language used around those symptoms in different ethnic groups, and then actually be going out and seeking where those people actually are in the community and how they're being received at the moment in primary care. And as Rachel's alluded to, this is something that there's leaders within Leicester, where we are with Kamlesh Kunti and others, who are really trying to develop exactly these kind of approaches. But they're in very early stages, and I think it's something that's going to be really important because long COVID may not present in terms of the words that people may use to describe it may be culturally different between different ethnic groups.
I've got two more topics. The next one is examining ethnic variability in long COVID symptoms and the effect on healthcare workers. So at paragraph 94 of your report, you highlight that healthcare workers, particularly those from certain ethnic backgrounds, face a higher risk of severe COVID-19 outcomes. Question, is there any evidence suggesting that long COVID symptoms manifest differently across ethnic groups?
I think there's evidence that symptoms are interpreted and described differently amongst different ethnic backgrounds and different cultures, I expect. So we know that, say, for the breathlessness, where my research is mainly based, that actually sometimes people will use pain to describe the distress of breathlessness. And actually a healthcare professional, if they hear pain, they'll interpret that completely differently. I expect that I think everybody, especially before we knew what long COVID was, really struggled to articulate what they were feeling because there is just this, blast of symptoms, not just and again, not trivialising chest pain if someone's got chest pain, but that can be one symptom, say, for a cardiac condition. Long COVID, many people have 20 plus symptoms. So I think everyone finds that very difficult to describe. And then if you put cultural differences around health seeking, when it is felt to be appropriate to go and seek health, are you worth going to seek health? There's a lot of stigma, particularly from certain populations, not just ethnicity, but more in areas of social deprivation. Sometimes people feel that they've deserve to be ill, and therefore that stops them seeking healthcare. If they've heard that actually there's not that much trust in a healthcare system, and if already they don't have much trust in a healthcare system, that will all negatively impact our ability to actually support that population.
Okay. My last question on this topic is this. Has there been any targeted research conducted to understand how long COVID affects ethnic minority healthcare workers compared to their counterparts?
So there's the Reach UK original study. They have definitely done further work looking at how long COVID has affected healthcare workers of different ethnic backgrounds. I'm not aware of all the results yet, but they've definitely got a series of ongoing research at the moment, so that is active.
Okay. Final topic. Again, at paragraph 79 of your report, you discuss the role of social deprivation in driving health inequalities related to COVID-19 and long COVID. Question: could socioeconomic factors such as limited healthcare access or lower awareness of long COVID symptoms contribute to underreporting within deprived communities?
Absolutely. And then I think we've also heard how much effort, time, energy it's taken to navigate the healthcare system, even by people that have a skill set to be able to do it, albeit completely challenged while being ill. So, yes, I think, yeah, definitely.
And what public health measures could be implemented to raise awareness and improve access to care for long COVID in socioeconomically deprived populations? And again, trying to help the inquiry here in terms of trying to look for positive things that could be done, recommendations.
So again, I think it would be good to consider case finding, because as we've just heard from Rachel, not only do you have problems with people then actually seeking healthcare, it's whether they've actually got healthcare available that they can even seek in some of these areas, because we all recognise that it's still often quite difficult to access primary care for some individuals. So if you actually have better ways of then actually going out into the community and trying to identify where there are challenges in terms of ongoing symptoms, so actually trying to then identify cases and then being proactive. So again, trying to then think about how you can then proactively try and help to manage those symptoms in people in those areas.
And finally, and I'm just piggybacking on something you just said earlier to Ms. Peacock, from what you said earlier about better support from NHS for workers with long COVID and occupational health, it being very rigid and inflexible, are you aware of reports of disparities in employer support for ethnic minority healthcare workers? Are you aware of any reports of disparities?
So not aware personally of that, but absolutely there are disparities that have been in the public domain around the way different ethnic groups have then been treated in terms of their exposures at work, and then therefore their risk of then long-term consequences. So that I appreciate is in the public domain, but not something that I've personally confronted.
Milady, those are my questions.
Thank you, Mr. Thomas.
Thank you.
Thank you very much, professors. You'll know far better than I, but one of the most distressing things about long COVID, I understand from sufferers, is that not being believed. And I'm sure on behalf of all the sufferers, they want me to thank you and your colleagues for all the work that you do, not only getting recognition for the condition, but trying to treat and support people who have it. So thank you for all your clinical work and your research work, but thank you also for the work you've done for the inquiry. This may be your last appearance, I don't know, but if it is, thank you for all the help that you've given.
Oh, thank you.
Right, 10 o'clock tomorrow? Thank you.